Hello everyone, very good morning. On behalf of the All Gujarat Ophthalmological Society and CIPLA, we welcome you on this encyclopedia webinar on the refractive cataract surgery. The aim of this webinar is to make you understand the various aspects of the cataract surgery, which is no more nowadays a simple cataract surgery. As we all know, the patient's demand and expectations have increased very much, and everyone wants a 6/6 or better vision. So I hope this webinar will help you in achieving those practical points. And we have an allied group of speakers as well as the panels. In the speakers, we have Dr. Sonu Goel, Dr. Hitesh Chheda, Dr. Rahul Navalkar, as well as Dr. Rahul Chaudhary. And now I would like to request Dr. Sharmil to introduce Dr. Rahil so he can continue his talk. Over to you, Dr. Sharmil.
Good morning, everyone. So I would like to introduce Dr. Rahil Chaudhary, who is a director of the I7 Hospitals, Delhi. I don't remember whether he knows or not, but we have met before in the ICL's meetup. And he is a very young and budding cataract and refractive surgeon. He is going to speak upon the femto and refractive cataract surgery. Over to you, Rahil.
Thank you, sir, for those kind words. And at the outset, I would like to thank CIPLA and Gujarat Ophthalmological Society for giving me this opportunity. So I'm just starting with my screen share now. And can everybody see my slides now?
Yes, perfect.
Right, sir. So I'll be speaking on Femtosecond lasers in refractive cataract surgery. So we'll be talking about tools that we have with Femto laser that can be used to get excellent outcomes in cataract refractive surgery. So talking about Femto laser, basically we have four kind of tools that can be used. The first one can be used to make capsular marks or limbal marks. Then we have the option of doing LRIs or AKs. Then we can make very accurate triplanar incisions. And then also we have something called as special capsular cutting, where we can customize the Capsulorhexis according to our needs. So very comprehensive topic, a very detailed topic, but I've tried to cover each and every subheading in brief detail. So let's start with femtocapsular marks. First, we have to understand that putting the IOL at the right axis is very important. Every degree that the IOL is rotated from the axis it is supposed to be, we are losing about 3.5% of its power. And the basic calculation, we all know, we all agree that about 10-degree IOL rotation, 1/3 of cylindrical power is lost. And 30-degree IOL rotation, we lose the whole power. And 30-degree is not much, it is just 1 clock hour. So it is very important to put the IOL bang on the axis to get the best results. Now, we have automated iris marking systems, the digital overlay systems like Varion, and they are highly accurate. But the only issue is that sometimes corneal overlays can produce parallax errors, which can be to the tune of 2 to 5 degrees. So femtocapsular marks can eliminate this parallax effect because the plane at which we are putting the IOL is almost coinciding with the plane of capsule. And IOL rotation can be assessed on slit lamps because the marks stay there. And one of the reasons people were not adopting it was they used to fear that capsule is weakened by a different kind of a marking system. So now we also have studies which clearly state that capsule is not weakened. So just a diagrammatic representation and an animated representation of how these marks look. The depth of these marks is usually 0.3 millimeters. And the sweep angle is usually kept at 10 degrees. So you can see in this picture, I have highlighted this with red. This is how the marks look. And this is where the toric IOL has to be aligned. And since the plane of the capsule is almost the same as plane of IOL, the parallax effect that we get with the overlays, corneal overlays, the digital overlays, is almost minimized, on it becomes zero. Now with femto laser, you also have an option of putting limbal corneal marks. But to be very honest, I have not been using this much, because if we have to put marks on limbus, the digital overlays are better. Now, when we are talking about femto-refractive surgery and we are talking about treating astigmatism with femto laser, I think we all agree here that when we are doing a femto-refractive, then we are talking of astigmatism which is less than 1 diopter. Because whenever the astigmatism is more than 1 diopter, I think we will all agree that we all are using toric IOLs. So when the astigmatism is to the tune of 0.1 to 0.25, it can be easily managed by using properly aligned CCIs. Femto incisions can be placed right on the steep axis, taking in account the surgeon's comfort position. CCIs can be, as I discussed, placed on the axis. It can reduce the astigmatism to the tune of 0.1 to 0.25. And up till 0.3 diopter astigmatism can be corrected with OCCI of an incision size of 2.2 millimeters. And OCCIs, opposite corneal incisions, can also at times be used with patients having null cylinders, as temporal incision will induce some kind of a with the rule astigmatism. So basically, Femtosecond LRIs or AKs are used to correct astigmatism up to 0.75 diopters, in which 0.25 diopters can be managed with the use of CCIs. So just covering a few basics before I get into Femto LRIs. We all know that whenever we put these limbal relaxing incisions or AKs, they cause a flattening effect. And the flattening effect increases with the depth of the incision. So as the incision becomes deeper, the more flattening effect it has. So consistent depth is very important. And the next thing we know about the LRIs is that the longer the arc length, the greater the effect. And arc lengths from 45 to 60 degrees have a coupling effect of 1:2. And the next thing we know about LRIs is that small optic zones have more effect. That means the closer you are to the visual axis, the more effect it will have. Less than 7 millimeters can induce irregular astigmatism, and it has more effect in older eyes. And incisions on vertical axis have greater effects compared to horizontal incisions. Now, the manual incisions, the problem is that the depth can be irregular. However, we have very good quality diamond knives available today. But again, there can be situations of irregular depth, irregular length, and it could be on the wrong axis. The advantage with the Femto LRI, in one word, if I have to say, is precision. So Femto LRIs can do wonders. It can be magical with people having multifocal IOLs, having residual astigmatism. Femto LRIs are OCT guided and controlled. You have the facility of iris registration and being bang on the axis. The coupling effect is very predictable. The length, depth, angular position, optical zone again can be accurately the way you want it. The depth is usually kept at 80% and the zone is usually kept at 9 millimeter. It is safe. We don't have any perforations. and the photo disruption of corneal tissue causes less regression compared to the manual. And additionally, what you have with femto LRIs is that you can put intrastromal incisions where you don't have to open up the epithelium or disrupt the epithelium. You can just have intrastromal incisions. They are minimally invasive. They are very comfortable. There is no epithelial growth. There is less risk of infection. But the only thing we have to be careful about is that when we are putting intrastromal incisions, we have to be in the anterior 80% of the stroma and not the posterior. Because if you go posterior, if you go deep, it has an opposite effect. And to get the same effect with intrastromal incisions, you have to put a longer arc and it has to be closer to the visual axis, preferably 7 millimeter diameter. Now, one very big advantage of femto LRI is that you can titrate the incision. So I've seen some ophthalmologists, some surgeons, what they do is that they put in an LRI, but they don't open it. They remove the cataract, they raise the IOP to 25 millimeters of Hg, mercury, and then they are doing an intraoperative aberrometry. And on the basis of that intraoperative aberrometry, then they decide if the incision has to be opened fully or partially. So intraoperatively, you can assess how much astigmatism is the patient left with, and accordingly, you can titrate your LRI, which was never possible in manual MRIs. And in case you don't have intraoperative aberrometry, what you can do is that you can the next day do a pentacam and then see how much the patient has residual astigmatism and then titrate and open the incisions. And that can be so easily done on a slit lamp. The only issue with the intrastromal femto LRIs is that it is not titratable. So if you have to be in a position that you want to be able to titrate even the smallest of the smallest astigmatism, then you have to do a full LRI. But the ability to titrate is the biggest advantage that one can get with femto LRIs. Now, how to put this femto LRIs? We have multiple nomograms. We have the Donenfeld nomogram, we have the Nishman's nomogram, we have the LRI calculators. There are multiple nomograms available, but some nomograms people find it difficult to follow. So I think the Donenfeld nomogram is the most popularly used. However, now people have come up with their own nomograms with their own calculations to give you as accurate results as possible. So I am using the Donenfeld nomogram, and we have tweaked the nomogram little bit for the femto LRIs. So what we are doing is that we decrease the nomogram by 33% and reduce the optical zone to 99 millimeters. So basically, if the nomogram says that you have to treat a 60-degree arc, we are using a 40-degree arc. And we are keeping 80% depth. The spot size that we are keeping is about 3 microns, which is 3 microns apart, the distance. And I initially started with 1 millijoule of energy. But with time, depending on how comfortable you are, you can maybe use between 1 to 5. For me, 5 millijoules works very comfortably. Because the problem is that the higher the energy you use, the larger bubbles, cavitation bubbles you are creating. And then what happens is that they join together and burst open. So then it becomes similar to what you're doing with the blade. So if you want to do with the femto, you should be able to keep the cavitation bubbles as close as possible, but they should not be joining with each other so that you have the ability to titrate these incisions at a later stage. Then one more advantage that you can have with the femto laser is that you can cut the capsule in specific ways, like this one with interdigitating capsular areas, and then you can use special lenses for the same. So that was all for femtoastigmatism, femtorefractive surgery. I'm open to questions if somebody has any questions relating to this topic.
Excellent presentation, Dr. Chaudhary. We are all heading towards zero phaco energy and zero, ultrasound energy use. I'm sure you are also doing that.
Yes,
So
sir.
can you just share some light on that too?
So with femto laser, you have various options to perform nuclear fragmentation, in which there is one option which is the mesh option, where the femto laser is first cutting the nucleus into multiple slices, and then it is transecting those slices from between, creating very, very small chops, something like finger chips. And it is also softening the lens. So what happens is that when you have such kind of softening effect and cutting into multiple pieces, you can take out the nucleus just by aspiration. So some cases where we have a nuclear grade of up to 2 or maybe 2 to 3, there we can easily use this technique and give advantage of zero phaco femtosurgery to the patients.
So the advantage, which I believe would be that by doing this, is that by using less ultrasound energy, you have less corneal edema, less other things, and it would help in the use of ORA intraoperative devices in future.
Yes.
Along with these things, but 90% of the energy Bagh has stated in his lectures that he is able to reduce his ultrasound energy. Also, by doing the zero phaco energy on the soft cataracts, we can further reduce it by about 86%. So we really don't need to use much ultrasound just to break the soft. If the soft sticky cataract gets stuck, then we just buzz it to break that occlusion. Now, also you talked about intralamellar, but intralamellar, they say it doesn't have a long-term effect. Even the arcuate incisions may last for 6 months to 2 years but they're definitely better than blade or diamond blade incisions that we give.
Yes.
And by having a perfect capsulorhexis, the most important thing that you are achieving in Femtosecond is that you have a more effective lens position. There is going to be much less lens tilt, and this will help in getting your results for your astigmatic patients as well as for your multifocal and trifocal patients. So effective lens position has now become a very important criteria, which Dr. Sonu mentioned. So a lot of these new formulas are using this effective lens position to along with other factors. So that is how I think we get more accurate results after the use of Femto. Next speaker, you can invite. Any questions?
Can I just ask one question to
sure.
Dr. Chaudhary? I wanted to know your LRIs, which you say you open up the next day at the slit lamp. So how many days later can you open? Only the next day, or do you wait for some time? And how do you go about opening?
You can open the next day.
Yeah.
But usually what I'm following is that initially I used to open it the next day. But now what I started is that once you do the surgery, we wait for 2 weeks.
Okay.
We let the eye settle a little bit, let the eye stabilize a little bit. And then when you open it, what I felt is that you're able to more accurately titrate compared to if you do it.
Yeah, that's precisely why I was asking, because I felt the intraoperative aberrometry, even if you have filled up the chamber, doesn't really give you the real picture. You need to wait for some time till the wound settles in. And at that time, 2 weeks later, then how do you open those incisions? With what do you?
Easily open it on the slit lamp.
That is very simple.
Even 2 weeks later.
Yes, with the Sinsky support.
Okay.
So
Yes.
we can ask a question to Dr. Rahil.
Yes.
Deepan, sir.
Okay.
Regarding the Femto. First, we would like to know, Dr. Rahil, which Femto platform you are using.
Yeah.
Unmute, sir.
I've used the Lensar also and used the Lensex by Alcon also.
Okay, sir.
Now,
So can you guide us What are the difference between the two, and which one is the more useful in your practice, considering you have used both the things? It can guide the lot of
They,
new buyers.
they both are equally good. They both give excellent results. The advantage I find with the lensa is that you have an immersion technique in that, compared to the lensex where you have to use a soft contact lens. So sometimes with immersion technique, the results I feel is better because it avoids even the minutest of the minutest explanation, which can sometimes maybe change the final outcomes. So I feel
Okay.
that is a better thing. But both practically, if you look at it, both give excellent results. There is absolute perfect results with these technologies.
You are making the incisions regularly, or you are not making it
No,
regularly?
not regularly. I think probably in 5 to 10% of the patients who are undergoing femtocataract surgery, because I feel majority, about 80 to 90% people are still opting for microphaco. We give option to everybody, but limited to only the 10% who are undergoing the femto laser cataract surgery.
Depends on, you can ask, as you are using the Catalyst, a different platform.
See, now in Catalyst, the most important thing that he has pointed out is that we have a liquid optic interface. So now we don't have applanation, there is no folds on the cornea, and you get much accurate results. You're able to open up most of the incisions which you were not able to, of course, unless you have vascularization or a lot of opacities, we are able to open up most of our incisions. Now, the important thing with this, after that, talking about the liquid optic interface, is that whenever you are fragmenting the nucleus or softening the nucleus, here we go from 500 micron pieces to 300 micron. And he said that, finger chips, what we do is we have small cubes. And by doing that, a little bit more energy is used by the laser and the time also taken, but we are able to do near zero energy phacoemulsification in a lot of our soft cataracts. And this really leads to very, very crystal clear corneas. A good incision is so important because you get a good inflated back in the procedure, in the whole surgery, and your PCRs are less. With a good incision, there is less leak of fluid. And that is why there's less fluid exchange, less ultrasound energy used. So that is why ultimately your refractive results also are more dependable. But most important is the Capsulorhexis. The point that is that here you get a more predictive, effective lens position and lens tilt. And the lens is, especially with your toric and multifocals, it becomes so important that we follow this. A good Capsulorhexis is so important, and this allows us to deliver that. And
coming back to Dr. Rahil, just a minute, sir.
Yes.
Regarding the Capsulorhexis, many of the times, I have received the reviews that the Capsulorhexis is not free floating in case of this Femto Capsulorhexis. So, what is your take when you have used both these machines? And then, Dipan sir, you can answer regarding your experience with the Catalyst.
Initially, when we started off, the Rexis was not free floating. We had to actually take in a micro Rexis forceps and gently tear it apart. But now with the latest software updates, now when we do the Rexis, it is absolutely free floating. There is no problem in that.
Dr. Mohak, we have
both the machines? Okay.
100% we have free floating Capsulorhexis. Maybe just one patient might have had a small tag and then, we are just pulling it only, it must have come out. So that 100% I cannot say, but we get a very free floating. And the important thing is that nobody has talked about, I think he talked about the lensar. In the lensar, which Sonu mentioned, or one of the previous speakers mentioned, that you can, mark the capsule. So that is so important because you're right next to the intraocular lens markings. And if you have a small marking over the capsule, which is only possible in the lensar, not with the Catalyst and the Lensex and other machines as of today. And also the most important is in the next day, post-operatively, that whether you're 5 degrees, 10 degrees out, we are able to, there was a small question, very simple question asked Mohak. Do toric lenses alter the spherical aberration, or, It's a very simple question. So whenever you're using toric lenses, do you do anything else, or does it alter your final spherical aberrations? Sharmil?
I have not
Yeah?
observed anything.
Yeah, you're right, absolutely. Sharmil?
Sir, I didn't get your question.
By using toric lenses post-operatively, do you get any spherical aberrations? Spherical aberrations in the sense that do you get any higher order more, or let's even forget the higher order, that whether you get a spherical number post-operatively when you are using?
Yeah, of course, sometimes, but not more than 0.5 I've observed.
Yes. So you're absolutely right. You do not get any, most of these lenses are now manufactured so well that you do not get these things.
We have one more question for Dr. Rahil.
One thing, yes.
Yeah, sorry, Dr. Rahil, you can go ahead. Then I'll ask.
The one thing I wanted to ask, that when we are using the matrix pattern, I want to ask this, sir, that when we are fragmenting the nucleus first vertically,
yes,
the femto is bisecting it horizontally. Yes. So how many planes are you bisecting? So 1 plane, 2 plane, 3 plane?
No. I think we can, I think this is really, we really don't govern the number of planes as of today. We are using the standard software, and we only govern the size. Whether we want to have 500 micron, one cut to the next 500 micron, or 300 micron. The horizontal cuts that you are mentioning would be about 2 or 3, depending on the thickness of but the machine decides that. Because we are basically trying to make it into cubes. So, that is.
I have a question for the speaker. So,
yes, Vishal.
So I would like to ask Dr. Rahul and also Dr. Dipen Desai, sir, what is your experience regarding the intraoperative aberrometry, especially in the cases of post-refractive surgery when you cannot accurately measure the IOL power, or you like to decide based on the intraoperative aberrometry? So how is your experience?
So, before that, I would like to ask you a question, Dr. Vishal, which has not been discussed. You have the calisto. We all know that we are doing markings manually, which are very good. And I'm sure these new machines, the Varion and the Callisto, give you much, much more accurate results. Can you please say in a few words, share your experience with the Callisto, especially for the toric IOLs?
Yeah, I mean, compared to the marker system, these new markerless systems like Callisto and Varion, they are pretty excellent, and we have got new results. There are new case studies in the Journal of Cataract and Refractive Surgery that the toric alignment is more accurate and more within the actual intended axis of placement with these technologies compared to what you do manually. And one more thing is that with the manual markings, you are likely to get somewhat inaccurate results, because even if the patient slightly tilts its head like this or this, you are bound to get a false result. But with this Varion or Callisto system, it is getting your limbal vessels fingerprinted. So no matter how your patient rotates his or her head, you are going likely to have a very accurate result.
Now, see, there are certain situations, like you only said, that operatively you have ballooning of the conjunctiva, you have subconjunctival hemorrhage. See, because these principles are there, the principle over here is taking the mark of the peripheral blood vessels or in the conjunctiva. So now in these situations, what is your experience?
So usually what the Callisto does is when you do your biometry with the IOL Master 700, it takes your iris photograph, your limbal vessel photograph then and there. And before you have to match that photograph with your intraoperative Lumera photograph before you start the surgery. So before you do any manipulation or any conjunctival manipulation and all that, when the eye is virgin, you take that, you match these things. So there is no usually any problem with these systems.
No, because I understand when you're matching it preoperatively, but postoperatively, anyway.
I would like to mention that intraoperatively, sometimes the Callisto goes off when there is ballooning, because it's based on the limbal vessels. In that aspect, Varion is much better because it's looking at the iris pictures. So that, it tends to not go off as much as the Callisto goes
So,
off.
but by and large, just for the audience, both of them are very comparable.
Yes.
Very
Excellent.
comparable. But as far as the question you asked, Dr. Saab, is Vishal, is that using the aura, intraoperative aberrometry or aura. See, very simple to first of all, they're so expensive.
Yes.
Two, the important thing is that if you have that machine with you, you require a library of lenses. Whether you have a multifocal lenses or a toric lenses or this, you require a library. So it is very difficult for private practitioners and people in our country to use those systems. They are very good for aims, for research purposes. As of today, I would feel. This is my personal opinion.
I would like to add that one thing which sometimes I follow, suggested to me by a friend of mine, Dr. Rishi Swarup, is you take out in RK patients, you leave the patient aphakic, take out the cataract, leave the patient aphakic, and go in as a second procedure after the refraction. I know it sounds like too much, but the accuracy and predictability is much more than trying to estimate something.
Rishi has very good patients over there. They are so damn finicky. They will rape us. Okay, doctor, even after explaining them that, what happened, they will tell us the next day, okay, doctor, sir, you didn't put a lens.
But I just mentioned that it's a good option for those who don't have intra-aura.
Yeah,
I mean, not all of us can really.
Right.
Just one question to the panelists, may I?
Yes, of course.
Is anybody trying to incorporate the parallax effect if they are using the Varion? So maybe if initially the microscope is at tilt, so maybe once you finalize, just like this Isa mentioned, that we should go in with the 30 gauge needle and fine tune the final position of the lens. So is anyone like at the end of the surgery trying to incorporate the parallax effect that may cause a slight degree error?
But you require the machine, I guess, a Varion or a Callisto. Over here, I think Vishal can.
I think only Vishal has it.
I have Varion, but we aren't doing.
Yes, sure.
Yeah. I think the toric lens what I use is a bit forgiving. So 2 to 5 degrees is not really going to make too much of a difference, But with the Femto, I really like that aspect of those markers.
Okay.
Excellent, because I don't think that really weakens the rexes in any way, and it places the most accurate this thing, and that would be one of the top uses of Femto cataract, I would feel.
See, we are doing a lot of toric lenses from the beginning, but the basic question is that today, if we use imported or Indian toric lenses, I'm talking about in the last 3 to 6 months, is there any difference? This was one of the common questions asked by everybody.
I feel there is a difference. I feel there is a strong difference.
I also believe so, sir. Even not only that, even in the imported, if you see plate haptic torics, how many times you have to re-rotate them. I know people who have gone in twice and tries to realign them, and after even a month. Whereas with some of the hydrophobic lenses, which have they stick very well to the posterior, very adhesion tactile. So they stick very well to the posterior capsule, and the requirement of re-rotation is much less.
Yes. Have you got any experience with ultra smart toric? One of the Indian company has come up with these smart toric IOLs.
Smart toric, yeah.
No, I have
a lot of ultra smart torics, and I have not averse to the idea to use Indian lenses. But I'm very choosy. Like Dr. Mahok said, that the results with the imported are a little superior. The best toric lens, if I have to put only one company from the imported bracket, is Alcon. That somehow gives you very good results. I'd use the Hoya lenses and this and that and every lens on earth. But this is very good. But the Indian lenses are also good because we are living in a population where we want to treat 30-40% of our patients. Anybody over 7.75, 1.25 diopters, we must do toric intraocular lenses. And even if they cannot afford, we should try to do. And that is where the Indian category of toric lenses can be utilized. And many a times, even if the patient doesn't pay me money, I will do it. Then the patients ultimately they are happy. And ultrasmart toric, the only simple and the basic things are 2-3. That 180 degrees, 180 degree, you are keeping them. So that is a little easier. But then you have to be, when you're doing a temporal incision, sometimes your markings have to be deeper inside to the central cornea. And the second thing is that these plate haptics, somehow these plate haptics, because they are bugbears, they are quite little bit more stable in my hands compared to the C loops. And that is why Rayner has come out with not serrated, but the rounded, the haptics have been rounded, and semicircles have been made in the outer part so that it doesn't rotate. But single plate haptics do work, and I'm sure Mohak, you have a lot of experience with ultrasmart torics.
Actually, I've stopped putting ultrasmart torics, but nowadays I've got very good experience with the biotech lenses.
Yes.
They are very good lenses as an Indian company. I am also using a lot of toric ICLs as well, and I'm getting as good as result as the imported ones. So I would suggest if you have to use one Indian company's IOL, it would be biotech. Of course, there are no financial interest, but so far we have put more than 500 lenses, and our experience has been very good, spot on. It is always around 0.5, 0.25 residual.
Yeah, other than ultrasmart toric, also we use a lot of biotech Indian toric lenses. In our opinion also, I have got surprises in the last 3 months also after using these toric lenses. Few surprises you do get. But as Sharmil said, we have to, evaluate more. Then we talk to the company people evaluate all the whole case history. They say they will come back, but they don't come back with good answers. They don't come back with good answers.
They always have some fault in manufacturing and something like that. They are going to give you freebies.
One very basic question to the panelists. How do we assess that the IOL is rotated post-op?
Yeah.
Very, very basic, just for the audience sake.
What I do is, I, as a rule, on first post-operative day for all my toric lenses, I dilate. First post-operative day. And on the 7th. So that is one thing is very essential. Second thing is that with the slit, with the patient sitting, I make a thin, tiny slit and put it at the exact location as where I would have done the markings. And I will see whether the slit is coinciding with the intraocular lens markings. Sometimes the slit is not coinciding with the intraocular lens markings. Then I will see on my slit lamp, this is at, let us say at 35 and this is at 45 degrees. So I'm 10 degrees off. And this gives you fairly accurate results because there is no change of anything. The same patient is looking straight ahead, same slit lamp. And, this should be any other suggestions.
What he's saying is the first post-op day. What he's saying is regarding the patient, you have done the surgery, lens is well in place, patient comes the next day. And how will you diagnose the patient? First of all, we have to hear the patient's complaint. Patient will immediately complain. If the rotation is more, patient will complain of the blurring of the vision. Then we check the patient. And what usually I do check the patient vision as well as auto-refractometer. And there is always some residual amount of auto-refractometer is there. And of course, just like Dr. Deepan said, we do dilate all our patients compulsory, those who are undergone this toric procedure, and we see the markings. Any other input from other panelists can help?
So as you said, on the autoref, when you get those readings, there's one astigmatism fix, which is a website where you can feed in your things, and it tells you how much to rotate, how much off you are. So that is a really useful website.
See, also what happens is that, the refraction sometimes, especially in these specialized lenses, earlier on is a little variant. So you do not, it's 100% you have to, that's the first thing you would do, vision and refraction. But a simple thing like, just aligning the slit, very fine slit will give you the same information as to how much, and all this information has to be put together. And you have to do your pentacam analysis for the corneal curvature. You have along with that, and after a week, again, you have to do your pentacam analysis in all these patients. And then only you can, finally jump onto a conclusion.
Mr. Mohak, the Hoya accuracy also has an option to know whether the IOL has been malaligned and you can realign. So you already have the Hoya accuracy. So Would you like to share something?
Which one you said? Vishal? Eye trace, right?
Eye trace.
I think it does help for
Does
regarding the pro-operative workup. But post-operatively, I haven't got that much of surprise, so I don't have to rotate that much. I think it's maybe out of 500, 2 or 3 patients are there. And just like I'm following the basics, just like Deepan sir said, you dilate all your patients compulsorily, as well as you make the patient sit once the operation is over. Even post-operatively, you make them sit in the your OPD for 3 or 4 hours. You make sure there is no rotation. So by following this standard protocol, I'm not getting that much of rotations, to be very frankly. So I don't have to use that much of eye trace for my post-op patients.
See,
I do use them for pre-op.
You got a very important point, Vishal, of ray tracing. Today, the newer IOL formulas, as mentioned, that Ibulix from Germany and another formula, which I forget the name, mentioned by Dr. Sonu, is going to use ray tracing technology. And ray tracing technology, even for if you go to see, he does so much of refractive surgery, it is going to play an immense role in the future, ray tracing. What is not, we have, the newer intraocular lenses is the, a monofocal lens. Let's talk about, you get refractive. You are going to get refractive surprises, whatever you do, whether it is monofocal, toric, multifocal. 90% are today, with all the latest formulas, 90% you are within plus or minus half. You have another 10% to deal with. But these new lenses, Calon Vision, when they came out, is that, light refracting lenses. So ultraviolet light is put onto these lenses. Usually after a week, first day they assess this, after a week, and after a week they change the refraction. Like if it is minus number that you want to correct, then you will give in the periphery, because the monomers, they collect in the center. If it is a hypermetropic thing, you go give it to the periphery, and likewise, or you vice versa, and that is how they correct. Another very, very promising lens, if you ask me, is the perfect lens, where you put in the lens, and after a week, the femtosecond laser you can do on the lens and recorrect the residual refraction that you have. And they're both, at least the Calhoun Vision light correcting lenses are FDA approved now, and people have started using. The limitations are $6,000 for these lenses, and you have to wear dark glasses. Ultraviolet light you cannot allow the patients to have for the first month, so for at least 3 weeks. And so there are a lot of limitations in these lenses, but they are the future.
There is one question for Dr. Hitesh. Yeah,
yes.
Sharmil. Go ahead, Sharmil.
Yes. Interrupting in between, can I please take everybody's permission to exit? My next seminar is just starting in 5 minutes.
Yes, Dr. Rahil. We were glad to have you. We thank you very much.
Pleasure.
We look forward to see you again, sir.
See, Rahul, we have a bunch of, I'm the only elderly person over here. There is a bunch of young brigades, and you are one of them. And we wish you all the very best.
Thank you, sir.
You have a long way to go with being your father's son, and keep at it. God bless.
I'll stay in touch.
So we are continuing we have another 5 minutes only, sir. We have another 5 minutes
I
only.
would like to wish all the viewers as well as the panelists and speakers, today is Mother's Day. Please do not forget to wish your mother today and do something special.
Yeah, so coming back to the question, Dr. Hitesh, there is a question that how will you tackle the
today's topic that we have chosen is refractive cataract surgery. We all know that it is the need of the day, especially with the advent of specialized intraocular lenses, as well as the patient expectations. Of course, we do require new equipments and a lot of investigative tools and new formulas to help us achieve these goals. Dr. Sonu Goyal is a personal friend and has been a great teacher. His special interests have been cataract and refractive surgery. He has lots of presentations, international and national, on his name. But he's a passionate teacher. Also, that he's member of, he has been given many awards, which of course it is not possible for me to enumerate in this webinar. So let me now invite Dr. Sonu Goel, who will tell us on the newer intraocular lens formulas, as well as the other technology and equipments that go with it to achieve a near perfect result. Dr. Sonu, all yours, sir.
Thank you, Dr. Dipin Desai, for that very kind introduction. And I'd like to thank the All Gujarat Ophthalmological Society for giving me this opportunity. So without wasting much time, I would like to start my topic. And I'd like to thank Dr. Amit Shah, Dr. Jayesh Babishi, Dr. Pradeep Gandhi, Dr. Mahendra Thakkar, Dr. Mohak Shah, and Dr. Priya, the Chairman Scientific Committee, the CIPLA, and all the moderators and the panel for giving me this opportunity. The topic given to me is itself very challenging, optimizing biometry IL formula, and I like to make it as interesting as possible, but believe me, summarizing in 20 minutes is very difficult. So, optimizing biometry and IL formula, I do not have any financial disclosures to any of the products. It is a highly disappointing feeling to face a refractive surprise and an unhappy patient despite a beautiful surgery. And we all know cataract surgery in this modern era has become a refractive surgery. So 2020 is the vision which is required by all. Accurate IL power calculation is a multifactorial discipline. Accurate measurements, accurate surgery, accurate follow-up, accurate optimization, and the accurate formula is what is all required, and these together end up giving a patient that 2020 vision which everybody requires. So when we look at the measurements, so biometry is one important tool towards achieving this, and of course the keratometry reading and the topography which will help us to attain this. Optical biometry is very accurate. Biometry is no longer a significant source of error. Axial length measured either by an ultrasound or laser can be as close to plus minus 0.20 millimeters with an ultrasound, and with a laser, this error can boil down to as low as plus minus 0.02 millimeters when we are using a biometer which is based on an optical principle. The keratometry is very important, and it is next to the IL formula, which is the key. You have to take at least 2 readings and maybe from 2 different instruments. Be sure to identify a post-basic case and use topography to check the axis. So I, in my Toric patients, would always try to verify the axis looking onto the topography. The major sources of error in the IL power calculation, the foremost is the effective lens position. And believe me, this is the major cause of the surprises, the myopic or the hyperopic shift that we encounter in our daily practice. Axial length and keratometry readings then encounter the second and the third place, and there are several different other causes of errors in the IL power calculation. So I'll quickly take you through a journey of the biometry and the formula, working for the short eyes, the long eyes, the toric IL power calculation, and the post-corneal refractive surgeries. So biometry, and we believe because small biometric errors can induce high post-operative refractive errors, optical biometry is a preferred over ultrasound. Why? It is very accurate. It is a repeatable tool. It has integrated formulas, more variables, and you can always find out the fixation point. Bang on fovea, you can accurately calculate out the axial length. If you look at the accuracy of the axial length calculation by different mechanisms, the applanation gives you close to plus minus 0.24 millimeters. So that means there is always a scope of error of as close to 0.24 millimeters. Vis-a-vis in the immersion A scan, it goes down to plus minus 0.12 millimeters. And with an optical, it is hardly plus minus 0.01 millimeters. So calculation of the axial length, the corneal power, the anterior chamber depth, the white to white, the lens thickness, ultimately boil into the formula and then IOL power calculation. So as I have already told, the ELP is the major source of error, almost 35 to 40%, followed by axial length, which is 17 to 26%, and the K readings, which is close to 22%. Now, a quick graph, if you see here, on the left side is the applanation A scan, the middle is the immersion, and the right side is an optical device. The applanation A scan falsely gives you a short axial length because you have a variable corneal compression. The corneal microaberrations, the higher operator dependency are the sum of the sources of IOL power errors. For the immersion A scan, there are easier alignment with the shell, there are no corneal contact, improved consistency, and it is less operator dependent. So if you see the bar in the center, it's almost close to zero as compared to the applanation where it falls slightly on the myopic side. But when you talk about the partial coherence interferometry on which our biometers are based, precisely the IL master 500. So these are non-contact devices, and you can, with the phakic, pseudo-phakic, phakic IOLs, staphylomas, silicon oil filled eyes, that is not limited by the wavelength or the retinal thickness variations. So you get an accurate measurement of the power required. So if you classify the IL power calculation formulas, right from the history, we have the historical or the refraction based, the regression, the SRK1 and SRK2, and then we have what is called as the Vergence formulas, and these formulas are variable dependent. So these can be two variable. By variables, we mean whether they depend upon the axial length, the keratometry, the anterior chamber depth, the lens thickness, or the white to white. So you have the Holiday 1, SRKT, and the Hoffer-Q. The three variable formulas, the most common is the Hagees. The 5 variable formula is what the Barrett Universal 2 that we use nowadays. And the 7 variable formula is the Holiday 2. And when you talk about the modernization and towards what is happening new is we are working on the artificial intelligence where we have the Clark neural network and the Hill RBF formulas. And very interesting is the ray tracing technology, which is close to giving us the Oculus and the Phaco Optics Olsen formulas. So trying to achieve that near 2020. I would like everybody to have a look very close because this is a common question which is being asked, which formula and when to be used. So I've tried to summarize. The formula selection is very simplified. And if you see on the table, the left lowermost, the Barrett 2 extends its arms from the shortest to the longest eyes. So I think it is one of the most important formulas which helps you from the extreme of the axial length positions. Same goes with Holiday 2 and the Hagees, but believe me, SRKT, the Hoffer-Q and the Holiday 1 are usually meant for the normal axial length, not for the extremes of the axial lengths. And yes, when you have the normal anterior segment and you have all anterior segment, so then Barrett 2 and the Olsen work for all these extreme conditions. There are certain things to be considered when you go ahead. The axial length measurements, the anatomical characteristics is very important. You have to check whether the fixation is central. It should never be an eccentric fixation. You should rule out posterior staphylomas. All these modern OCTs give you a glimpse of the retina where you can detect whether there is any retinal pathology present or not. And hence, you can also check the fixation on the fovea. Post-operative target refraction should always be set towards low myopia, always avoid hyperopia. The axial length adjustments, the Wong-Kok adjustment in eyes with axial length more than 25 millimeters has by default. Just look at the lower table. The error caused by 1 millimeter of the compression in an average eye can lead to a 2.5 diopter of the error in the IL power calculation. If you have a long eye, this might be a little forgiving to 1.75, but what happens when you have a short eye, a 1 millimeter compression would give you an error which is close to 3.75. Now, this is what has to be taken when you're dealing with the extreme of the situations. Now, when you have a short eye, the key for accurate IL power calculation in short eyes is an accurate measurement of the axial length and adequate IL power calculation formulas. And believe me, the IL manufacturing standards plus minus 1 diopter, they fall into plus minus 1 diopter for powers more than 30. So even if you have a high power, still the chances of error become very high. So you have an axial length measurements. Axial measurements, they can be errors and they have high impact. So 1 millimeter, as I have already mentioned, can lead to 3.75 in shorter eyes. And if you talk about the effective lens position, there has to be an accurate prediction of the ACDs, which is very important. An error caused by an anterior chamber depth measurement of 0.25 millimeters can lead to, in a shorter eye, a surprise of 0.5 diopters, and which could be sparing in a long eye to close to 0.1 diopters. So for the short eyes, when you're talking of two different systems, basically the Lenstar, which works on optical coherence tomography, you have the Olsen, the Barrett, and the Haigis formula, which work very well for short eyes. And when you have an access to an IL master, you have the interferometry on which this works. You have the Barrett and the Haigis formula, which are incorporated in them. A good article which shows the Haigis to be superior over Hoffer-Q and SRKT when you're dealing with short eyes. And similarly, this paper by McLaren and et al. Again signifies the importance of Haigis formula in extreme hyperopia. When you're dealing with high myopia, a very good article by Jodhbir Mehta describes the importance of Barrett Universal 2, the Haigis formula, and the Olsen formula in extremes of axial lens. C constant is a new concept which has been incorporated in the ray tracing technology, and Thomas Olsen has been working on it. And this is how the C constant works. From the very center to the periphery of the lens, this is what is the C constant, and this gives you an accurate power calculation. So talking about the toric power calculation, which is very tricky, nothing different from after calculating out, feeding out into the formula, you have the IL power. But what is important is the keratometry values. And then what is important is the cylinder and the axis. So you always have to look into the sources of error, which could be the surgical induced astigmatism, the posterior corneal astigmatism, the effective lens position on the cylinder, the position of the fovea, and the post-operative IOL tilt. Now, these are the certain gray areas when you're dealing with toric power calculation. So you always have to consider the SIAs. You have to be consistent with your axis that you're doing. You have to always plan for a smaller incision, and believe me, consider the centroid SIA. You have to consider the effect of posterior corneal astigmatism when you're dealing with. So this table describes the source of error when you're dealing with toric IOLs, and delta is basically the difference between the corneal measurement techniques, which accounts for almost 18.2% of the errors or the noise when you're doing a measurement in cases of toric IOLs. So an accurate corneal measurement is what is important when you're deciding for toric IOLs. So posterior corneal astigmatism, I think everybody knows about this PCA concept. The posterior cornea is basically a minus lens. It is against the rule. So you are trying to, with the rule astigmatism, you tend to overcorrect and you tend to undercorrect the against. So you have to accurately work out that. So the Baylor toric nomogram is what is required. And this comes as an easy help. And if you see closely here, when you have a with the rule 1.7, I would go in for an IOL of 1 diopter, as against if I have an against the rule astigmatism of 0.4, I would step up by 0.7. So you have to step up and step down when you're dealing with the rule and against the rule. So in deciding for toric IOL, both the magnitude of the cylinder and the axis are very, very important. So we can measure the posterior corneal astigmatism by using the Scheimpflug imaging, by optical coherence tomography. We can have the intraoperative biometry, and we can have color LEDs. We can also estimate the posterior corneal astigmatism. So now there are two terms which I want to use: measurement and estimation. And I would say, which one is better? Estimating seems to be better than measuring. So that means these formulas have certain factors which are imbibed, by which they can estimate the posterior corneal curvature and thereby help in interpreting the axial, the right power of the lens. So when you're dealing with post-refractive patients, the major gray zones are the SRKT, the Holiday, the Hoffer-Q, the Barrett. They all use the keratometry or the radius of curvature as the predictor of IOL position. Now, what does this translate into? When you have done a patient with a refractive surgery, the axial length always remains constant, but your play readings go down. So that means there is always flattening in terms of the keratometry readings. So after myopic LASIK or PRK, the corneal power decreases, but the IOL position does not. So there is always an underestimation. So you will have always a hyperopic shift. Similarly, after hyperopic LASIK, the opposite occurs. So a 1 millimeter change in the ELP would boil down to almost 2 diopter of change in the power.
अभी वापस ही कर
So if you see the picture on the left side, we always know that between the anterior and the posterior curvature, there is always a fixed ratio. When you do a myopic ablation, the anterior and the posterior ratio changes and it increases by a certain factor. When you're doing a hyperopic LASIK, you are steepening the anterior surface. So anterior by posterior goes down, the ratio goes down. And when you're doing an RK surgery, there is a flattening of both the anterior and the posterior surface. So there is both the change of the ratio and there is a change of the corneal asphericity. And that bounces to the error that we have. So either we have a formula which is a double K method where you have pre-operative K readings also, and you have a post-operative, and you can otherwise, if you have no data, then you can either go with an average amount of diopter that you have corrected, you can guess the K value, or otherwise if you have a Scheimpflug and OCT system that can always check the posterior and give you an approximate anterior curvature. And that is what boils down into giving an accurate biometry. So there are again the keratometry errors that can be corrected by an accurate K correcting functions which are incorporated in the Haig's L and the Barrett, and then measurement of the posterior cornea by the Scheimpflug or the OCT system. You have online calculator. A quick word: if you do not have an access to these systems, you can use your the immersion biometer. You can feed in the data online, and then you can access the formulas that you require. And the Barrett is universally available on the ASCRS and the APACRS websites. The ray tracing formulas, basically the Olsen, are incorporated in the LensStar and the Pentacam, and the ray tracing formula Oculix is available in the Cassia. Sometimes you have patients with phakic IOLs and you have to do the power calculation. The material, the polymer or the acrylic material makes, these are faster materials. Basically divide them into two categories, faster and slower. Silicon is slower. So faster material would give you a shorter than the real axial length, and the IOL you get a more power. And so you have a post-operatively myopic shift if you have an eye seal inside the eye. For a silicon, you always tend to have a hyperopic shift. So you have to have a correct measurement for that. So optical biometry, a quick word about the optical biometry. These are basically divided on the basis of the technology that they use. The ILMaster 700 works on the principle of the swept source biometry, and the LensStar has the optical coherence technology. So 500 had the partial coherence interferometry, and in the figure, if you see, this is how the laser infrared 780 works. And for the 700, it is the swept source, which takes 2000 scans per second at almost 30 degrees to each angle. So this is how the picture and the fixation with the telecentric keratometry they call with the 3-zone system in the ILMaster 700. So it gives you the axial length, the anterior chamber depth, the lens thickness, central corneal thickness, white to white, pupillometry, keratometry. And then this is the LensStar, which again gives you all those parameters. Why optical? The swept source, basically the standard deviation or repeatability, if you see, the central corneal thickness is as low as plus minus 2 microns. The anterior chamber depth is plus minus 10 microns. The axial length boils down to plus minus 9 microns, and the keratometry is plus minus 0.7. So that basically speaks of the accuracy with which these equipments work. So you can always have the fixation check for more accurate measurements, and you can always see the foveal pit. And if you don't see a foveal pit, that means there is a poor fixation. You can see the lens tilt, and if you see the axial length measurements, these are almost, with the ILMaster 700, have gone down to as low as 9 microns. So this boils down to an improved refractive outcome in terms of the induced IOL power calculation error, which is close to 0.26 in cases of IOL Master 700. They have a better penetration with the swept source. So majority of patients, 90% of the patients you can measure, and you can also look in for macular pathologies. So quick word about the best performing formulas, and by this I mean the all eyes. So if you see on the left side, the Barrett Universal 2, the Olsen HS, and the Hagees are the three formulas which are fitting into almost all axial lens. So again, you have axial lens between 22 to 25, and in extremes less than 22 and more than 25. You still have the Barrett and the Barrett Olsen fitting into all these ranges. So these are the commercially available systems in the world market: the Nidac, Lenstar, Galilei, the Tommy, and the Topcon, which the available optical biometers. And this is a quick comparison overview of the different, the central keratometry readings, the number of zones, the axial length, and their consistency. So I'm sorry to have given you more of migraine or hypertension or stress, because ultimately it is that webinar stress which we all are forcing you to undergo. Thank you so much.
Thank you, Sonu, for a most comprehensive talk. Because whatever you have said is so important to get the final results. Is Vishal there?
Yes, sir.
Vishal? Vishal, can you simply, if you can, along with Dr. Sonu, sum up how to switch to better formula? Simple words, Like,
as Sonu sir has already showed the slide where he has shown that three formulas: Hagees, Holiday 1, and
Others, please mute your mic.
See, he has already most of the people may not have the meters and the higher end, formulas to work with. So is there anything like simple things like, please, try to, is there anything that anybody can give simple hints?
Yes, sir. We can always, if you don't have access to optical biometer, I think the immersion ultrasound is always a better option compared to the applanation, and it gives as much accuracy. And one thing is you can optimize your formulas, especially the A constants, and there are various online calculators and the optimizers available, like Dr. Hill's website. You can go there and you can optimize your have your personalized A constants for Hagees and surgeon factor also, and you can get better accuracy and less the mean absolute error. And also you can use, there are multiple tools available which are freely available, and also gives you an option to modify your results. There are a lot of tools like Barrett Universal as well as Toric formula, even the Hill RBF, which is artificial intelligence based calculator, which is also a very good tool. You can also access to Holiday 2 surgeon formula using the Hicksop website, which I can show you later on. So there are various options available.
To sum it up, what I would like to say, you use the Barrett online calculator, Barrett Universal 2 formulas, as well as the Barrett Toric calculator, because they are freely available on the internet. If you don't want to do that, just keep in mind, for the normal eyes, SRKT works very well. For longer eyes, you have to use Hagees, and for shorter eyes, you have to use Hoffer-Q. This is
or Holiday 1.
Yeah.
I agree with you. Now, in the short and long eyes, again, if you can just sum up, like, he has very well given this talk, Sonu, but, just one formula for short eyes, let's say, a Holiday 1 or a Hagees or Hoffer-Q. I think better than Hoffer-Q now, they believe, is Holiday 1. For everybody who has other than the 700. The other thing that I would like to, point out is, in the post-refractive challenge, you have already said that, this works. We are using the ASCRS calculator.
I think Dr. Rahil is going to speak on that only. So we save this for him.
Then, we should save it for him.
Okay, so we now move ahead with our third speaker, who is Dr. Hitesh Chheda. He is the director of the Asian Eye Institute, Mumbai, and he is a special interest in cataract and refractive surgery, and he will be speaking on management of regular astigmatism. Over to you, Dr. Hitesh.
Thank you. At the outset, I will like to thank the All Gujarat Ophthalmic Society and the CPLA for inviting me. I will be sharing 5 tips which will help a general ophthalmologist to incorporate toric IOL in their practice. The regular astigmatism, when the 2 parallel rays of light do not come to a point focus on or near the retina, and regular astigmatism, the 2 principal meridians are perpendicular to each other. Types are the with the rule, against the rule, and the oblique astigmatism. With the rule and against the rule, you should be very familiar with. With the rule astigmatism is when the vertical meridian is steep and the minus cylinder is at 180 degrees, most commonly seen in the younger population. Against the rule, as the age advances, it shifts towards the against the rule. The horizontal meridian is steep, minus cylinder is at 90 degrees, more common in the older age group. Oblique astigmatism, when the 2 meridians, the greatest refractive power is at in the oblique meridians. Incidence of astigmatism is almost 30%. So out of 10 people for cataract surgery, around 3 will have some form of astigmatism, and we need to tackle that at the time of the cataract surgery. Visually significant cylinder, up to 0.5 diopters, the patient usually may not feel the blur, but as the cylinder increases up to 1 diopter, the visual acuity drops down to almost 612, and as the cylinder power increases, it goes with 4 diopter cylinder, it goes down to almost 6/60. So we need to correct the cylinder at the time of the cataract surgery itself. We got an opportunity to do it at the time of the surgery. What are the symptoms that you get with the astigmatism disturbance, distance as well as near? Night vision is affected most so in the daylight. There is a confusion in the letter. Similar letters like N and M, there is asthenopia, ocular fatigues, headaches. All these things can be corrected at the time. If you try to correct with the toric IOL, this can be corrected at the time of the surgery. How to measure? There are various instruments available to measure the astigmatism. The auto-K, the most commonly used. Manual keratometry is becoming obsolete, but it has a role. It helps you in evaluation of the tear film quality. By the quality of the Mayas, you can make out the tear film quality. If the Mayas are not very good, you know that you are dealing with some tear deficiency. Even you can make out the tear breakup time. If the Mayas are good initially and they deteriorate over 4-5 seconds, you know that you are dealing with the tear film deficiency. And you can treat those patients beforehand, before the operation, so that the tear quality does not deteriorate in the post-operative period. There are various other instruments, IOL master, topography, eye trace, slit scanning, and simpler cameras. They all help in the measurement of the K. At least use 2 instruments to corroborate your findings when you are managing the toric IOLs. The first clinical tip is manual keratometry does have a role. It helps you in the pre-operative assessment of the tear film quality and the pivot time. The topography is the most commonly used second instrument. You should be all versed with the pictures of these with the rule and against the rule astigmatism. This is with the rule astigmatism with the vertical lines, you can correct up to 1.5. Against the rule astigmatism, usually they do not get corrected with the LRIs. LRIs have very minimal role in these cases. Usually I do it on an IDEC OPD scan, which gives me a total astigmatism of the entire eye. It gives me the corneal astigmatism. It gives corneal astigmatism is the anterior surface of the cornea, and the internal astigmatism, which is giving me the some evaluation of the posterior corneal curvature. In the cases, the internal astigmatism reflects the posterior corneal curvature. In very few cases, when there is an IOL tilt or where this IOL subluxation, the internal astigmatism will reflect the lenticular astigmatism. So the second clinical tip is always measure the posterior corneal curvature. If you use the Barrett's formula, incorporates a general 0.5 diopter of against the rule of astigmatism for the posterior cornea, which will work very well in 80% of the cases. But in 20% of the cases, you will have a problem if you are not posterior corneal curvature. Management of these patients wearing those glasses not comfortable. They find the surfaces are elevated. Even they find difficulty in walking down the staircase. What you need to do is in these cases is you have to reduce the distance between the cornea and the glass. The frame should be fitting very snugly on the eye. There should be minimal space. Your finger should not go between the glass and the chip. That will solve all these problems. And because cylindrical spectacles give a lot of issues, we have an opportunity to correct it at the time of cataract surgery, and you should give an option to the patient, because if you count the cost of the spectacles over the next 10 years, then also the cost of the surgery is much better for the patient, and you should incorporate these things in your counseling part. Why toric IOL? There's very high visual demand from the patient nowadays. The results are much more predictable as compared to the LRIs, and it reduces the residual post-operative astigmatism significantly. The three common errors that occurs with the toric IOL: first one is the measurement error, measurement of the case. So always use two instruments to corroborate your findings. Second is the calculation errors. When you put all your data into the IOL calculation formulas like Barrett or any other Alcon toric calculator, when you put the data, there can be some error in putting the data. And the third one is the alignment error. This is intraoperative alignment of the axis. The error can occur in these three places. I usually use Barrett's calculator for all my cases. I take a printout of the result and keep this ready in my operation theatre at the time of the surgery. The two things which I look for when I select the IOL power, the spherical equivalent, I use the first myopic reading, and when I select the cylinder, I always undercorrect. Do not overcorrect. Overcorrection will lead to flipping of the axis, and which is not very good for the patient. Leave behind 0.5, 0.75 diopter and always undercorrect. Two things: in very highly myopic eyes, the anterior chamber is very deep and you have to use 0.5 diopter more cylinder. And very small hyperopic eyes, less than 22 diopters, the AC is very shallow and you have to use 0.5 diopter less cylinder. These two extreme situations you should keep in mind. When you are correcting the cylinder, always undercorrect. Leave behind 0.5, 0.75 diopters. Do not overcorrect and avoid flipping of the axis. I've just selected few examples, clinical examples, and how I do my decision making when this is the right eye of the patient, approximately 1.33 diopter cylinder at 86 degrees, and the horizontal meridian this is against the rule of astigmatism and paired with the toric IOLs. So against the rule of astigmatism, LRIs usually do not work, and more than one diopter you need a toric IOL. This is the second case. Left eye of the patient, the cylinder is up to 0.5 diopter, up to 0.75 diopter. I just ignore. I do not do anything for the astigmatism. You can go ahead with the multifocal, trifocal IOLs. This is the third case. Here the vertical meridian is steep, 43.49 and 93, and approximately 1 diopter of cylinder. This is with the rule of astigmatism, and the LRIs do very good results over here. Up to 1.5 diopters, I usually correct with the LRIs, and more than 1.5 diopters, I will go with the toric IOLs. For the reference marking just before the surgery, the most important thing is make the surface dry. Just mop all the clear film from the fornices. This mark means for quite a long time. Very minimal instrumentation are required. General ophthalmologists can easily incorporate this in their practice. I usually do the marking just before taking the patient in the operation theatre in the sitting position. I just share a small video of this is the left eye of the patient, 65-year-old, and the intended axis is 155 degrees. Whenever I implant the IOL, there is slight degree of rotation clockwise.
I think we have lost his screen sharing, I guess.
Yeah, yeah, one minute.
But no, Hitesh, we request you to go through 2 or 3 slides because we could not hear a thing.
Yeah.
Yes, yeah. I do implantation along with continuous irrigation, and always opt for 1 or 2 degrees less than what you are running, because in the post-operative period it is going to move in the clockwise direction. I do not do the hydration of the wound. This is intracameral antibiotics, and that's about the rotation here. Rahil has already spoken about almost 30-degree rotation is just 1 clock hour, and you can do the entire correction. So the alignment is the most important. In the immediate post-operative period, I usually evaluate on the 3rd day when the cornea is clear. I just put the patient on the autoref and see the readings. If it is within or plus or minus 0.5 cylinder, I'm okay with it. But if you get a reading like a compound cylinder plus 0.75 sphere minus 1.5 cylinder, or plus 1 sphere with minus 2 cylinder, then you need to be careful. Go back to your initial measurements, calculation, and then look for the alignment, whether IOL has rotated or not. Whatever you need to be done has to be done within the first 7 to 10 days, maximum 2 weeks, because later on it will be very difficult for you to realign the IOL. I'll just sum up. The manual keratometry has a role in the tear film evaluation. Astigmatism has to be evaluated in almost all cases. Always and usually do not work. You need a LRIs. Can be done more than 1.5 diopters. You can go ahead with the Toric IOL. Thank you.
Thank you, doctor, for the wonderful talk. Sharmil, you have any questions to ask?
Yeah, I have a question which I came across I think a year back, which I would like to discuss. Is that I had a patient who showed -1 astigmatism on autoref, but when we did the optical biometry, we just didn't get any any astigmatism in the measurements, and we repeated it multiple times. At that time I did know that it should be because of the posterior astigmatism, but like many people don't have optical, the machines which can know the posterior astigmatism, to know the exact measurements. So what would a regular ophthalmologist do in such cases, right? Considering that autoref measurements and the optical biometry measurements are totally separate and different.
The Barrett's calculator is there. Barrett should be used because it will take care of at least 80% of the cases. But still, in 20% of the cases, Barrett's can also, because it is an estimated posterior corneal curvature which is incorporated in the Barrett's.
But sir, in Red-Star, we already used Barrett's formula.
No, Sharmil, you have asked a very valid question that you have a posterior corneal surface problem which you could not detect otherwise. So definitely the IOL Master 700
yes.
does definitely it calculates all this. Today, presently, what is happening is that even if you have posterior corneal curvature defect, it is being calculated depending on the power of the intraocular lens, only on basis of assumption in the present day formulas. So as you rightly said, that you are already using it, but pentacam is a very necessary thing in assessing this thing, and this will give you a proper hint as to what you should be doing. And you can nullify it after you put in the pentacam results.
Agreed.
Dr. Sharmil, I just want to clarify, you had a cylindrical power on the autoref and K, but not on the lens star.
No,
But-
not on the lens.
So you mean to say the autoref picked up a posterior corneal astigmatism and the lens star did not?
Yeah, it overall picked up the refractive error. Rather,
No,
I would
not
say.
refractive error. Is it autoref or auto K?
No,
If
it was
it's
auto ref. It was auto ref.
So autoref is of the astigmatism
Entire
of the
eye.
entire eye. If
Yeah.
you're looking at auto K, then both the auto K and the lens star are working on the principle of anterior corneal astigmatism.
Correct.
When there's a mismatch in that, in my case, when there's a mismatch, I always go with the lens star. Because if you have taken Dr. Hill's criteria for validation, then the lens star keratometry readings are even comparable to the IOL Master 700, though that is because it was already an advance compared to the IOL Master 500.
Correct.
So,
So, but I would like to say that I operated that this case a year back, and I consulted many the companies of lenses that what should I do, because these are two different things coming up, and we opted to put a non-toric lens. Patient was ready, in fact, to go for a toric lens, but we opted not to. And we actually got -1 cylinder, and that patient was freaked out. Like I said, I don't want numbers, and why did you not put a toric lens? So then I had to explain that we didn't get anything in the lens star, and so we had to opt for this. But then it did come as a -1 astigmatism post-operatively.
In fact, I have another case which Dr. Hitesh and we are on one group where it was the other way around. It showed me this thing, a cylinder. I opted for a non-toric lens. And post-op residual, there was suddenly no residual astigmatism, So I told the patient that, counseled him that you would require a toric lens, but we ended up with, you'll require a spectacle correction after the surgery. He ended up with no spectacle correction.
Can it be that? So can it be my case would have been a posterior astigmatism and your would have been a lenticular astigmatism?
Yeah, it's possible, because that's why lens tilt and everything which is calculated in the 700 is really of importance.
700 has the definite advantages of posterior corner surface measurements, the lens thickness measurements, and this is where it helps us in getting the right power. Now, Sharmil, I'm not saying you are a fantastic surgeon, but sometimes when we are giving incisions, especially the clear corneal incisions, we do not get a definitive correction. Okay, you will be 0.25 down or 0.5 down or 0.75 down or even 1 down. And it all depends on so many factors. So is the pre-operative and post-operative case measured or something?
So I don't remember the case exactly right now, but I will of course share it on the group if I come up with the things again.
So we've done a long back study on limbal incisions versus clear corneal incisions, and we found that clear corneal incisions have such a big standard deviation of the amount of cylinder it causes or the effect it has compared to limbal incisions. So they are very forgiving. Sometimes you can get surprises like this, but you did the very best in that situation. Now
I think, Sharmil, you have the pentagram, so next time you compare both on both the instruments.
I know, but that day the patient had just come for surgery and we couldn't do the pentagram. We had it at the other branch actually, so
you can understand. So, for toric lenses, it is very important that we get the powers right, which has been ably demonstrated by our speakers. But also, even if you have a little bit of a decentration, the amount of light actually reaching the fovea is decreased by 20%. So these patients will have a lot of difficulty in reading and in other situations. So we have to be very careful even in this, as far as the centration is concerned, not only access placement. The most important thing that I have learned in my practice is that the intraoperative tip is that after doing your complete phaco, you are 5 degrees away, let us say you're even in the center. You want to check with a 30 gauge needle after hydrating all incisions. Go from the side And with the 30 gauge needle, just manipulate the lens into its final position, keeping in mind that the patient is very perfectly looking into the light, where you have the visual axis, and you are rotating the lens to that. Another thing is that on the first post-operative day, I dilate all my patients to see whether I have got some rotation. Maybe even after a week you can do it, because as the previous speaker has said, even up to 15 days there is no issues. But we have to get back into the lens into position. Otherwise, these patients will be very, very unhappy. Any other practical points, like, Mohawk or Vishal, if you would like to say, Doctor?
I would like to add one thing, that IOL Master 700 is no doubt the gold standard because it directly measures the posterior corneal astigmatism. But even if you don't have IOL Master 700, even if you are using something like Lenstar already has a Barrett formula which mathematically presumes the posterior corneal astigmatism, and you can also use the Baylor nomogram, which the Sonu Goel sir has shown. It is very excellent and very accurate. And you can also use the free Barrett formula, which also estimates the PCA. And some of the IOL manufacturer companies like Johnson & Johnson and Alcon, and they also provide the facility for assuming your PCA. So it can be circumvented.
See, very important in the investigations, which has already been pointed out, is that you must do at least 2 topographic readings. Whatever machines that you use, 2 different methodologies or principles have to be used. That is a very important thing in trying to get your multifocus and your toric lenses right. After doing a good topography, everything else, once you have an optical biometer, there are less chances of error. But the other thing with the 700, and the important thing is that even in your hard cataracts, which you are not able to work with the 500 OCT 500, you are able to get with the 700. So you get more patients, and especially in our country, we need patients come in usually a little late, so it does help. Okay, anything to share, Doctor? Just a minute, we have time. Dr. Chaudhary, would you like to add anything on, these specialized lenses of how people can be more careful?
I think we have extensively covered, and we have discussed on minute details as well. So we can proceed with the session now. On to the next speaker.
Okay.
Vishal?
Yeah, I would like to introduce our next speaker, Dr. Rahul Navalkar. Just to give you a brief introduction about him, Dr. Rahul Navalkar is founder and director of the Gulmohar Eye Clinic at Kandivali, Mumbai. He has been practicing as a phaco and refractive surgeon since last 18 years. After DNB, he completed his training in phacoemulsification at Sankar Netralaya, and he has also undergone LASIK and pediatric ophthalmology training at LVPI, Hyderabad. He has been a member of several reputed national as well as international ophthalmic societies like AAO, ESCRS, and AIOS. Also, member of editorial team of Indian Journal of Ophthalmology. And his key area of interest are phaco and refraction. So he will be speaking about on the topic of cataract surgery after the patients with post-refractive surgery. So, Dr. Rahul, over to you.
Yeah, thank you, Dr. Vishal. Yeah, can you see the screen?
Yeah.
Yeah. So thank you for that introduction. And at the outset, I'd like to thank all Gujarat Ophthalmological Society and CIPLA for inviting me for this talk. And yes. So normally this topic which is covered, post-refractive cataract surgery, concentrates mostly on the IOL power calculation and the biometry. But Dr. Sonu Goel has covered quite a bit of the points on this. So I am at liberty to cover many of the other aspects. I would first like to acknowledge a lot of guidance from these two geniuses, Dr. Warren Hill and Dr. Graham Barrett, who have done wonders for the world of ophthalmology, especially in the field of biometry. So why is this problem so big? Why do we need to discuss this post-refractive surgery? As you can see, it was in the 70s that RK was first performed, and PRK LASIK is been around since the late 1980s. Now, if you consider an average age of 20 years when the patient underwent these procedures, an RK patient would be almost 60 years old and the LASIK patient would be 50. So they are all moving into the cataract bracket. I believe we haven't yet seen the deluge of post-refractive cataracts that we will be seeing shortly in the future. There's also a small but significantly growing number of patients with other procedures like phakic IOLs and intraocular. So we cannot look at it only from LASIK point of view. Now, what are these problems? I want to categorize these into these 4 headings basically. Biometry related problems, which is what is commonly discussed. But I would also like to touch upon the IOL related problems, intraoperative problems of these procedures, and ocular comorbidity problems. So what are the biometry related problems which are very often discussed? What happens in a radial keratotomy is that because there's a flatter peripheral cornea, a protruding peripheral cornea, there's a kind of flatter cornea. This overestimates the corneal problem. And it's especially worse if the optical stimulus. In LASIK surgery, there's a flattening and there's a change in the ratio between the anterior and the posterior corneal astigmatism, which the corneal refractive power goes for a toss. So, as Dr. Desai was mentioning, the effective lens position, which is a very important aspect of all the newer formulae, that is affected with these. It's very crucial for the newer formulae, and that is changed, especially in myopic LASIK. It's underestimated because of the flattened cornea. Because it assumes as the cornea is flattened, but the anterior chamber depth has not changed. And so it underestimates the effective lens position. As a result, the entire IOL power itself is underestimated and post-refractive outcome is a hyperopic error. So how does one overcome this? Now, there are various methods described. A corneal topography method, a clinical history method, hard contacts over refraction method, intraoperative retinoscopy, pre-operative keratometry, regression formula, net corneal power determination. So let us just briefly touch upon these things. The first method, using corneal topography, you ignore the SIM-K values and go only with the central corneal curvature. So only the central zone. The second method, you can go with a clinical history method. But for this, as you can see, pre-operative records and post-operative refraction is very essential. In post-LASIK refraction is very essential to get. Now, if you go to the third method, you try to estimate with a hard contact lens over refraction. But in this, what happens is that the cataract should allow for an accurate refraction. Sometimes you have denser cataracts, you cannot really, get an accurate refraction done. You can also go into intraoperative retinoscopy method, but this is not usually advised or not possible after hyperopic refractive surgery. These are all the various now pre-operative biometry. Based on that, you can, if you have records, like nowadays for all our LASIK patients, what I do is give them a pre-operative biometry. We do a lens star and attach it to the LASIK file for future reference. Whoever is going to be the 20 years later, the cataract operating surgeon has all these values beforehand. But in the older patients, many of these patients, we don't have these records. And regression formulae, which we must know what type of prior LASIK treatment, laser treatment has been done. And net corneal power can be estimated by either a pentacam or the OCT. There are a number of other methods as enlisted here, but what are the commonly used post-operative refractive formulae? So these are, when it comes to, you have to divide it into LASIK and radial keratotomy, and there are certain which can be used in both, like the double K and the Hoffer Q formula. But things like LASIK, Hages L formula, we usually restrict it to post PRK or LASIK cases and don't really use it for post radial keratotomy cases. But what are the real commonly used formulae nowadays? Barrett's True K formula, which is available on many of the newer optical biometers, Sharma's No History formula, and Hages L. These are the three most commonly used formulae which are applied for post-refractive surgery. Of course, as Dr. Goel has shown, an online ASCRS post-RK calculator, which is most beneficial, especially for those who don't have access to optical biometer, is also really helpful over here. Now, these are some adjustments suggested by Dr. Uday Devgan on his cataractcoach.com website for an estimation of how much to adjust the IOL power in RK depending upon the number of RK cuts. This is what I do. This is a screenshot of what I usually use. I use the LensStar, and there are options of going to post-refractive and choosing the formula as well. This is just a short video to show how we go about this thing. When we are doing the calculations and you want to find out the IOL power after the biometry, you have to change the way you have entered. So you just go into post-refractive entry, which gives you an option of the pre-vision correction entries if you do know them. If you don't know them, you can leave that as a blank and go into post-refractive surgery, what residual power you have right now on refraction with your patient. But you also need to mention whether it's a LASIK, PRK or RK. Once these values are entered, then you can go ahead with your calculation. Now, in a LensStar, the calculations which are done, you have certain standards. Now, my standard is a Hages, though I use a Barrett's, but I switch between the Hages and Barrett's. Sometimes, based on this Hages, there is no formula which is given. You need to go and choose post-refractive, and you get a list of formulae. You get the calculations. You can get a Sharma's No History formula, or you can get a Barrett's True K. And you don't have to do any of those calculations, the long list of calculations that I mentioned before. But these formulae are also lens specific. As you can see in the Vivinax, Sharma's No History formula. So we have to go with a Barrett's True K. So these are all formulae which are kind of customized for every lens, available for these various lenses. So moving ahead to IOL related problems. What are these IOL related problems? We need to counsel patients very much in details, because you have to understand that they have very high expectations, because they have done LASIK, they have had spectacle free correction. So you cannot just estimate from our end. You need to discuss with them what are the possibilities. You have to make sure that they know that there might be some kind of refractive residual errors after the procedure, no matter what you do. So once they're counseled properly, they're not going to sit on their head immediately after the surgery. Now, which IOL to implant? As you can see in post-myopic LASIK, as we have more positive spherical aberrations, a negative aspheric, we have increased the natural positive spherical aberration of the cornea because of even in a wavefront optimized LASIK. So a negative aspheric IOL would be really beneficial. But in post-hyperopic or in irregular ablations or misaligned aberrations, you don't want to induce further corneal aberrations. So a total aberration. So you go with an aberration-free IOL. And I was speaking to Dr. Sri Ganesh, who has got his presbyopic LASIK done. And I asked him, what lens would you go ahead with? So he said aberration-free IOL. That was his game plan right from the beginning, where he has gone with a presbyon and done when he will require a cataract surgery, he's going to go ahead with an aberration-free IOL. So whether you should go with monofocal, multifocal or toric IOLs, there are two approaches. Now there are some doctors who would say in people who have had refractive surgery, I want to discourage it since I want to give them, the best quality of distance vision, and they should be okay with wearing reading glasses. I don't want to concentrate on taking away their, presbyopia or reading this thing. But there's one set of doctors who are going to say that, no, these patients already have great vision expectations which have been increased with a successful LASIK surgery. So because they have valued spectacle independence for the past 20 years, I want to try and maintain that kind of thing for them. So if you want to decide whether to put a multifocal or no, this is a very novel method I've come across on the net, where Dr. Wang from Nashville, he estimates the spatial tolerance. Now what he does is, with a mathematical formula, which I don't want to go into details, he calculates the spatial tolerance of that particular multifocal lens which he's going to implant. And based on the aberrometry and topography readings, he calculates the spatial tolerance of the cornea and see if there's a match. He considers a multifocal only if there's a match between the two. That means only if the lens the spatial tolerance and the corneal tolerance match. So this is one unique technique. I've never tried this personally, but it seems like an interesting thing. What are the intraoperative problems which you're going to face? This is also going to be different for LASIK and for RK patients. This seems very silly to mention, but we cannot forget that high myopes, even though they've undergone successful LASIK, are still going to have very deep chambers. So whatever complications go along with that. And similarly for hyperopes, you have to look at the shallow anterior chamber aspect of it. Now, phaco incisions in post-LASIK patients. We need to try and identify the LASIK flap and avoid, if you're going to do a clear corneal incision, you have to try and avoid the LASIK flap edge. But sometimes it's difficult to identify a very clear-cut LASIK flap edge. So one of the simple methods which I've heard and learned from Dr. Uday Devgan is to let the cornea dry for 30 seconds and lightly touch it with a Vexel sponge or a bud, and you can see the edge of the flap, and then you can easily avoid it. This way you just touch it a bit, you can see the edge of the LASIK flap and avoid that area. When it comes to RK, it depends upon the number of cuts. Sometimes if there are less cuts, you can go clear corneal between the cuts, and as you can see here, avoid the RK cuts which are there. You can make the paracentesis between one set of RK cuts and the main incision between the other clear corneal. But when there are more number of cuts, it is always safer to go ahead with a scleral tunnel incision. Not only do a scleral tunnel incision, one of the unique methods of making, because what happens is that with the high pressure in the anterior chamber, there is always a chance of blowout if they are very deep RK cuts. So you have to lower your parameters. You need to have a lower flow rate. You need to have a smaller gauge phaco tip to minimize the turbulence in the anterior chamber. One of the unique methods which I haven't had a chance to adopt but looks very promising is you can put a suture perpendicular to the RK cuts at the site of your phaco incision. That prevents those from really blowing up and gives a stability to that area where you're going to go ahead with phaco. And at the end of the procedure, you can even look at a suture to close the wound so that the anterior chamber stability is kind of maintained. Now, coming lastly to what are the comorbidity issues. We must not forget that glaucoma is very commonly missed in high myopes, and post-LASIK, as you know, the IOL power measurements are a bit haywire. So we have to really watch closely for glaucoma. And never forget that these myopic patients who have undergone LASIK are coming to you years later, and they are prone to myopic macular degeneration. So OCT, which is mandatory for all pre-operative cataracts at our place, we look very closely for this myopic macular degeneration. Now, in conclusion, I want to say, don't be too hard on yourself. I want to just show this case. This gentleman had he was one-eyed. He had lost his left eye to glaucoma after cataract surgery, after doing RK elsewhere. He was operated for RK in the late 90s. And then the right eye was operated by me for cataract with a clear cornea. Luckily, he didn't have too many cuts and I could find a gap between the RK cuts to go. But you see his post-operative AR showed haywire readings, plus 2.5 diopter sphere with minus 3.5 diopter cylinder. But surprisingly, his uncorrected visual acuity was 6.9, and he visits me regularly. He was from Nasik. He comes to Bombay, visits me regularly once a year, and he's doing extremely well and extremely happy. So don't be too hard on yourself, because in these patients, no matter what you do, you're still going to end up having a bit of a problem, sometimes a surprise. Thank you. I just wanted to be brief. Thanks very much.
Mohak, you want to ask any questions?
Yeah, there are, yes, I'm coming to it. I think it's a very nicely you have covered all the points, I guess. One question is from the audience regarding the ray tracing. How will you get the accurate ray tracing for the post-PRK and the RK patients?
So, can I go back to the slides, screen share?
Yeah, you can do that, no problem.
Frankly, I don't have too much experience with ray tracing myself. I use the Lenstar, and since it has more and more people are now stopping to really bother too much about calculating the accurate K and posterior and going with these formulae like the Haigis L or the Sharma's no history or even Barrett's true K, which is available on the Lenstar, and so you don't really have to make too much of entries into that.
Okay, so you feel that these formulas are good enough.
Yeah,
and regarding the post-RK patient, what you show in your case is absolutely correct. I also found the same result, that the auto-RSV is absolutely, very well. I don't know what is wrong. And when we take the vision of the patients are usually quite happy.
Right.
So take-home point is, no matter how hard you try, your post-RK patients won't be that happy compared to post-LASIK or the post-PRK patient.
So I would like to ask a question, and I agree with you, Dr. Mohak. Okay, would you do a toric IOL in these patients? Because they have some form of irregular astigmatisms and unstable refractions. So, the panel, anybody can answer.
Actually, this aspect one of the persons who really goes ahead with toric lenses in this is Dr. Arun Gulani. But he does not only go ahead with a lens, he looks at it from an entirety. If he feels there's a minor scar which is causing the irregular astigmatism, he wants to open up the cornea, take out the scar with his corneoplastic technique, and then move ahead with implanting. After that, calculate. So maybe do 2 or 3 step procedure, not do only cataract surgery and put a toric IOL.
See, what we do is that we do a lot of post-RK cataracts. And most of these had higher numbers and they have 32 incisions. So basically what I do is I try to make a near limbal incision as possible. Ideally would be a limbal incision, but I don't want to open up the conjunctiva. So here, sometimes it will open up. Of course, you go with the micro incision cataract surgery, but these will open up sometimes and most of the times. So what I do is that when these parallel incisions are there, one side is opened up, I may take 1 or 2 sutures where it has opened up rather than taking on the top. If it opens up, I take the sutures and you don't have a problem. Most important is counseling in these patients. Their expectations, usually these refractive patients are a little high, even though their corneas and eyes are bad. So if you are able to counsel, then if you are beyond 1.5 diopters, I think you can safely, and after studying the pentacam and seeing on the holidays, program, that what is the status of the cornea, how much irregular it is, then we can go and do a astigmatism correction with toric lenses.
I'm just quickly intruding because Dr. Rahil has to leave in 5 minutes. So astigmatism not identified by the pentacam, and the patient is consistently using 1.5 or 2 diopter of the astigmatism since long.
And it is not identifiable on the pentacam.
Yes. Which I really doubt.
Yeah. It may be a lenticular astigmatism. Maybe.
Exactly.
Sometimes,
so,
yeah. And
so
OPD scan can make it out.
Yes, exactly. So you have to, keep in mind that there's a total astigmatism. One is corneal, that is anterior and posterior,
Yeah.
another is the lenticular. So whenever
Right.
you are
Right.
calculating, so take home message is you always count for the corneal one. You remove the lenticular part because as such
Lenticular
you are
part.
going to
Yes.
remove the lens. So that is
Remove the
the take
lens.
home message. And there is one more question.
One regarding
Yeah,
this, I wanted to ask Dr. Desai's opinion.
Yes.
You use a IL Master 700, I believe.
No, sir. I am
Okay.
still using
So,
the 500. They are
500.
trying to sell me very vigorously, and I'm
Okay.
so happy
If
with my present results.
right.
And quite happy. Definitely, I will be thinking in the future.
Right.
The
No.
reason why I'm not investing right now is that so many new technologies are coming up,
Right.
and people are using
I can
Tomy.
give my.
Yes,
I'll,
sir. Please.
Yeah.
I'll
Uh,
the Tomy instrument. Tomy has
Yes.
come up with the IL mask. Similarly, it gives equally good results, and even in dense cataracts, you can get good results. Even in dense cataract, it gives a.
It
It
also
is
has
equivalent
ray
to IL
tracing,
Master 700.
that told me
Yes.
as ray tracing.
and it has ray tracing. That's the important thing also.
The
Right.
reason I was asking is because this residual, when somebody is wearing spectacle power correction, but it's not showing on the corneal this thing. Now, IL Master 700 is supposed to be calculating the tilt of the capsular bag as well.
Bag.
Do you, in your experience, I don't have any experience with this. In any of your experiences, have you seen this tilt in the bag which is causing the thing? Because lenticular astigmatism, due to the lens itself, you're taking out the lens. So there's no residue. But if the bag is tilted and that is giving, do you think that there is any role in this, or it's just
Frankly, we don't have the best solutions for a very tilted lens.
Yeah.
And if you come to know that this is here, the patients like an irregular astigmatism, you have to be very wary. You have to avoid. These are the patients that you would definitely avoid. Monk said that I would rather avoid doing a toric lens. I will do a monofocal lens. And
Exactly.
of course, but to answer more, what we do is that with 0.75. Is our basic cutoff point for toric intraocular lenses, where we try to correct by giving steeper incisions in the steeper axis in all our patients. We do OCCIs, which doctor mentioned, opposite clear corneal incisions up to 0.75, and we are getting very, very decent results, not the most predictive. Beyond 1.25 or beyond 0.75, if you have an against the rule astigmatism, please go ahead and use a toric IOL. 1.25 with the rule and any other, I would use a toric IOL.
And Dipan,
Yes.
what do you do if you're doing a multifocal lens where one
Yes.
eye there's no cylinder, means insignificant cylinder,
Yes, sir.
and the other eye has say 0.9, 0.8, 0.9 as you get?
Sir,
Would
it's a
you
very-
advise?
Sir, very important point I did not mention, and which up to 0.5 diopter cylinder is very forgiving. It helps all your multifocal patients, EDOF patients, trifocal patients for near vision and intermediate vision. So what I am now looking at to correct is a 0.5, let us say. So I would definitely operate on the steeper axis. I can do a small arcuate incision if I'm working with my flax machine catalyst. Otherwise, I can even give an arcuate incision approximately over there, or I can. We are very happy with doing 2.2 millimeter clear corneal incision on the opposite side.
So no toric IOL.
Corneal incision. So I don't use a toric IOL in these situations.
You don't.
Okay.
Yeah, because
One question.
we are adding more headaches.
Do you think for those who don't have access to a flax machine, would a manual clear corneal incision also work as good, as accurately
Sir,
in a multifocal toric?
Sir, I am a little bit of a aggressive surgeon, and I have been doing this for the last many years to correct even my monofocal patients. See, today when we are cataract surgeons, only thing that you want to be, one thing you want to be clear is that you do not perforate the eye. I perforated one eye in a minor way. I did not have to do anything. I may have, as you mentioned before, I don't puff it up so much. I puff it up normally, and if there is a leak, at the most you may have to take a suture which you can remove after a week.
Right.
So up to 0.751 we can see, because in our country it is not only about following other people. There are economics, patients, whether they can afford, what results you can give in a given situation is so important for us to make our day-to-day decisions.
Right.
Counseling is very important before.
Okay, so we just have a little time. One last question. It is the how will you plan for cataract with the pterygium, biometry, and the surgical steps?
Doctor, anybody would like to answer?
Actually, I was given a topic of irregular astigmatism earlier, in which this is what I was going to cover.
No, but I'm happy you didn't take it. There's very little you can really contribute in that.
Yeah.
Good.
So in this, in pterygium, what I prefer doing is counseling the patient, operating on the pterygium first, because I have seen that it really helps in the biometry, in my lens star readings very much, even though there is still residual some amount of scarring and everything remaining, but I think I get much better results. I was going to present one of the cases where we got a huge shift in the astigmatism. In fact, even in the Maya, sometimes the machine doesn't pick it up if that pterygium has been advanced quite a bit. So, but then it helps quite.
Yeah, so it depends on the grade of pterygium, whether you're from 1 to malignant. But the most important point that you have raised is that you must do the pterygium first. Otherwise, which Mo probably wants that answer. And
how long would you wait between the two procedures?
I would wait at least a month and a half.
Yeah.
I would wait till month and a half. Till month and a half is much safe.
How would you wait between the two procedures?
I also go with I would wait for a month between the two procedures, but sometimes it's not only the curvature. The tear film has been disturbed a lot because of the irregularity in the corneal surface. So we need to treat that besides. We need to treat that besides the pterygium as well. So that month gives you time to really get your tear film smooth to get the best perfect accurate readings you can.
Sharmil, you have to unmute.
Sorry. Also, the drops, the post-operative drops should have been also stopped. After that we can get the perfect measurements.
Okay, and there is one big looming question: is Femtosecond the future after COVID?
Well, let me try to answer that. See, it is the future, and especially after COVID, because the Ahmedabad Ophthalmic Society and All India members have been very concerned that whenever you are aerating anything, whether it is a cautery, whether it is a phacoemulsification machine or the phaco tip, here definitely SICS has a big role, but phaco we can. Everybody has their own opinions. I will share mine. You can definitely do phacoemulsification with all the precautions for surgeon, for other staff in the OT. And
no, sir, not that way.
And I'm coming to Femto.
Yeah.
Now, whenever we are doing Femtosecond surgery, it becomes so much beneficial because you're using the least amount of phacoemulsification energy. You have done the softening of the nucleus. You have done all these things. So definitely Femto in nucleus removal helps so much. So, and that is the only place where you have aeration. It is not during your intraocular, IA phase or other phases where you have aeration. But, as a general thing, we hope that the country opens up and we are all as ophthalmologists able to go and try to live as normal lives as possible before, otherwise this is just going to go on these arguments and we have to take a few chances and get back on the road, whether we do phaco or whatever you do. I think that's the message.
Dr. Rahul, your view?
I would like to ask all the panelists, suppose the Femto was the cost of a Centurion, would you buy it?
I think it's a blind answer to say yes, of course. And the
it is not,
cost should be less.
So it is not the technology which is in doubt, it is the cost of the procedure.
Of course.
You're right.
So when
Absolutely.
phaco came in, it was such an expensive thing. You could do ECC, you would say, why would I invest in so many lakhs for a machine? But it became the norm. I believe that femto also will become the norm, but cost is the main issue. Once that is worked around, if that is worked around, it would become the standard.
See, but today also, see, when I started phacoemulsification in the country in 1987, we were very humble beginnings, very simple, oldest, I have the oldest phaco machine in the country. Now, I used the Cooper Vision machine. It had only 3 settings of vacuum, and it was a magneto-restrictive. We have come a long way in phacoemulsification. From phacoemulsification, there has been a little bit of a step up with the flax. Even though I possess a fax machine, if you ask me, in our country, in our scenario, what is the cost effectiveness in a general practice for a private practitioner having decent practice of about, say, even 50 cataracts a month? I don't know whether it is worth it, sir. Even though I have invested, but I don't think, because it really, everywhere there is a cost, there is a benefit. The cost benefit ratio, I'm not sure. See, Sharmil could have got it before me and he hasn't got it. So he can answer why he hasn't got it.
He saved. He was about to order, but because of this COVID, he saved. He saved his hard-earned money, I would say.
But sir, one point. There's a research going on in the modification of IOLs with a femtosecond laser.
Yes.
Right. So I think femtosecond is of course going to stay, but there are much things going to come, and after that, all the formulas and everything would be gone.
Change.
Because we will put a zero diopter lens and then modify it with the femtosecond lasers. So that femtoseconds of course will come, and once they become cheaper, we all can buy it. That's, I think, future.
But Sharmil, what these buggers do is that the company people, they'll come out with a femtosecond laser to recorrect the perfect lens, which is known as the perfect lens. But at that time, it will be another platform altogether.
Yeah.
So we are not going to be safe from cost. આપણે મહેનત કરીને પૈસે કમા કે we are only working for the companies. At the end of the day, unfortunately, in ophthalmology, that is true.
So
Mohak, can you talk on that?
No, I'm just going to say 3 words. Whatever machines you have, you stick to it. Don't make any new investment, because after COVID, it is going to be havoc for the economy as far as I'm concerned. So whatever machines you have, you utilize them in the best way possible.
Right.
I think we are running out of the time. It was an excellent session. I would like to thank all my speakers as well as the panelists. And once again, I would like to thank the CIPLA and all Gujarat Ophthalmic Society for arranging this webinar. We'll be sharing the recording link soon in a day. So those who have not joined or joined it, they can take the benefit. Once again, I would like to say thank you to all my speakers and the panelists. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.
Bye-bye. I think we can leave.